Welcome, everybody. This is our fourth quarter provider advisory board meeting for the HB 23-1295 RAC section. And it looks like it's our last meeting for the year. I hope everybody finishes out the year wonderfully, healthy, happy, everything. I did post, just so everybody knows, last night I posted all of our 2026 meetings that I've scheduled based on the Google Forms that everybody filled out. So those are there to register moving forward for the public as well as the board. I will send out an email to the board members as well for you guys. So it looks like we're going to start out with David Smith was going to go over briefly a section, but it looks like he's not on currently. So we're going to bypass that. And Dr. Chapman, it looks like you're up.
So,
Are you there? Uh-oh. Dr. Chapman?
He's there.
He's there.
validate
Oh,
ICD.
you're
Hello?
cutting. You were cutting out, Dr. Chapman.
Okay.
I can hear you good now. So the floor.
Okay.
Okay.
All right. So I'll backtrack. So we've been talking about using guidelines to validate ICD-10 diagnoses for DRG audits and had some really good conversations with people, and the guidelines are not perfect. You can say that there are other guidelines or that they don't capture everything. And so I've really been trying to rack my brain how we do this. We've got to use the guidelines to a degree, but how we do this to take into consideration those one-offs. And so really where I'm going with this is when you look at how DRGs and APR DRGs are created, they're basically based off of resource utilization. And the idea is that facilities get paid for DRGs based on how much resources are utilized for that type of DRG. So really kind of where I'm going with this is I want to introduce the concept of we're going to do a very small DRG audit, hopefully towards the end of December, and how we're going to look at these things. So next slide, please. So I always try to bring up the mission. It's like, why are we even talking about this? And the mission is to improve healthcare equity, access, and outcome for the people we serve while saving Coloradoans money on healthcare and driving value for Colorado. And two other pieces to this. One, we have a statutory obligation to do fiscal oversight, and in Colorado, that's RAC audits. But number two, truly what we want is to take into consideration the interests of our providers. This needs to be a team effort, and I realize the RAC audits can use resources and are a pain point, for lack of a better term. And so we're just really struggling on how we make them fair and at the same time not onerous for the providers. Next slide, please. So if you look at DRGs and APR DRGs, again, the idea is they're looking at the resources utilized so that providers are paid based on how much resources you would estimate they're using to care for a patient. And you come up with the DRGs based on the ICD-10s supplied by the providers. In the RAC audits, basically you do validation of the ICD-10s as long as ensuring that the coding was done correctly. But how do you validate an ICD-10 code or diagnosis that was submitted to come up with this DRG? And then we get to the guidelines. You got to have some starting point, and the guidelines are not perfect. I understand that. Sometimes there are multiple professional society guidelines for a given diagnosis, but the bottom line is somewhere we've got to have a starting point. And they're not perfect, and they're subject to perception, and perception is your vantage point and how you look at things. So, next slide, please. So some of you have probably seen this before. This is from a 1915 cartoon, and just take a second and look at it and think about what you see here. And so, next slide, please. So again, depending on your vantage point, if you look at that top red arrow, is that an ear or is that an eye? If you look at it as an ear, it looks like a younger woman looking away from you. And if you look at it as an eye, it's the left eye, and then you can see the right eye. And then it looks more like an older woman looking more down and to the left of the screen, and the same thing on the chin, on that lower arrow. Is it a chin or is it the side of the nose? If it looks like a chin, then you see a younger woman looking away from you. If it's the side of a nose, it appears to be the face of an elderly woman. Same thing, necklace versus mouth on the bottom. So the whole point of this is just sometimes things aren't perfect, and we can look at things and be correct even though we have different answers. So next slide, please. So ICD-10 codes. I've had some really good discussions with some providers, and they bring up some real valid points. And one of the things that comes up, particularly with sepsis, is well, Medicare requires us to do these sepsis bundles and do alerts. Those are not the same as ICD-10 codes. Bundles are early recognition programs. They're designed to alert and encourage early recognition and treatment. But just because you started an alert or started treatment, in the end, if the patient does not turn out to have sepsis or whatever you're discussing, you can't use that ICD-10 code to come up with a DRG. So initiating treatment protocols does not equal confirming diagnosis. Next slide, please. So, perfect example, the STEMI alert. Somebody comes in via EMS with chest pain. STEMI alert is called, concerned that the person's having an acute MI, and time is muscle. If they don't get treated, they lose heart muscle and have worse outcomes. Same thing, stroke alert, sepsis alert. But if the patient doesn't turn out to have an MI after a STEMI alert, you can't use the ICD-10 code for an MI. And the same thing goes for stroke and sepsis. Next slide, please. So these guidelines, and I truly have spent quite a bit of time because I've heard some really good feedback. And so sepsis 3, when you look down at the bottom at the underlined area, sepsis 3 should be defined as, and I've heard some arguments, and they're legitimate, that, well, no, that really wasn't sepsis 3. But if you read the papers, they actually say this is what we should define it. Same thing with the Phoenix criteria for the pediatric population. Next slide, please. The Glenn criteria that are used for malnutrition. Again, if you look at conclusion, this is from the article, it's a consensus scheme for diagnosing malnutrition in adults. Next slide, please. I've had a discussion with one group of providers, very legitimately said, well, Aspen is recognized, but this is an article from 2025 in the Aspen Journal, where they looked at validating after 5 years whether the GLIM criteria were relevant, and basically they came up with that it was a good guideline to use. It's undergone extensive validation. There's some variability in the populations. As best I could research, I was trying to look at how many people met Aspen criteria but not GLIM criteria, and vice versa. My impression is more people will meet GLIM criteria than Aspen criteria, but I can't state that as absolute fact. So So then we've got these guidelines, we've got different perceptions. What do we do? Next slide, please. So where are we going to go? Again, there's no perfect answer, but the decision that we've made is that we're going to start out with a very small DRG audit. We're going to use these guidelines. I'm working with HMS, which is the RAC vendor, to see there's issues about proprietary information, what guidelines they use. But my argument is, well, that's something that the providers have got to know what guidelines are going to be applied. So hopefully we can publish those on the website. But then as HMS comes up with preliminary findings of potential overpayments, I'm going to be working with their physician advisors and looking at these and saying, okay, maybe they didn't meet SEP3 criteria, or maybe they didn't meet GLIM criteria. Let's look at what they actually did to treat the patient. What resources did they utilize? If it's a sepsis patient and they were in the ICU for 3 days, they had a clear infection, looks like sepsis, smells like sepsis, but doesn't quite meet the SEP3 criteria, the tie is going to go to the runner. Again, it introduces some subjectivity, but at the same time, I think it's better than just saying, okay, we're going to strictly go by guidelines. And the flip side is if somebody meets the criteria, for example, acute kidney injury, but you do absolutely nothing, or malnutrition, you don't do calorie point counts, you don't do anything, then that one's not going to be put through, because it's got to be a combination of both meeting some type of clinical guideline validation, but also using looking at what resources were utilized. And it's still, there's some subjectivity to it, and not everybody's going to love it. But we're going to do this as a test of change. We're going to try this out, and then hopefully we can get feedback for people. And part of what, if people want to dispute a finding of overpayment or a preliminary finding, then one of the things we're going to ask for is say, show us that you treated this patient, that you used the resources that you would use for a septic patient. So we're going to try. Like I say, we've actually reached out to some of the other states to see what they're doing, but I haven't gotten feedback yet on that. But we'll move forward. So next slide. So the goal of this, and I realized when I was looking at these slides that I have a typo there, but the first one is to carry out the Health First Colorado mission. And there's an extra Colorado in there just for fun. Fulfill the statutory obligation of oversight, but also we want the providers to be invested in. We want to take their interests into consideration. And I realize that the billing and coding and all this stuff is so complex and so resource intense. So we really, our goal is to make this fair. And hopefully, if we make it predictable, it will not end up with a lot of findings in the future for RAC audits. So next slide. With that, questions, comments, any thoughts?
I think it's reasonable the direction you're going, especially the idea that the tie goes to the runner. If we're using the resources for a certain diagnosis, then it should be counted. And if we use no resources, then probably shouldn't be. So I'm okay with this direction. My own personal thought.
Yeah. And like I said, I'm always open. If somebody has a better idea, always open to listening.
All right, Kelly, I think we're back to the agenda. Unless anybody has any other questions.
Megan, did
Real,
you see real quick, sorry, that Sarah had a question
oh, no,
on when will the November 13th slides and recordings be available?
the November 13th, they're not on, let me double check. I thought they were up on the website. For the provider advisory board, or let's see, talking about stakeholder engagement. I believe that's stakeholder engagement. So I will have to double check that for you. They should be up. So if they're not up, then they'll be up by the end of the week. All right. Um, I'm gonna have David Smith jump in real quick, and we're gonna go back and give you guys a rule change update. Are you there, David?
I am here.
All right, welcome.
Sorry about the previous technical difficulties. Good afternoon. My name is David Smith, and I work behind the scenes on RAC issues of a legal and regulatory nature. I want to take a few minutes of your time to shift gears and to let you know about RAC program developments of this nature. First, in October, CMS approved the department's state plan amendment for an effective date of August 6th. The state plan is a document that serves as our contract with CMS. It's a complicated and Byzantine kind of document, but it really serves as the backbone of the Medicaid program. But this effective date corresponds to the effective date of Senate Bill 314. During the last legislative session, the General Assembly passed comprehensive reforms to the RAC program, which serves as the nature for a lot of the discussions amongst this group. Arguably, though, the most significant change is that an overpayment will be determined at the end of the audit process, and the initial findings will be preliminary in nature. So these changes required an emergency rule change to the program integrity portion of our regulations, which set forth a different and conflicting process relative to Senate Bill 314. So on November 14th, the Medical Services Board approved changes to our rules that exempt RAC process from the existing regulation. On January 9th, in a month or so, the Medical Services Board will make the emergency rule permanent. Part of the department's obligation is to provide notice to stakeholders of rule changes, and part of my discussion with you is to serve that purpose. That being said, as the department resumes RAC audits, we hope to bring a separate RAC rule that addresses any gaps relative to Senate Bill 314 that are identified by the department as well as the provider community as we undertake these audits once again. That's all I had, Megan. I would be more than happy to answer any questions for the group.
All right, thanks, David. Does anybody have any questions?
What were the most significant changes that are being implemented?
Relative to 314, you mean?
Yeah.
Yeah. So, but previously when HMS would make audit findings, they would send the provider an overpayment letter. Well, we turn that around, and the overpayment is not determined until the end of the process. And 314 has a very specific and different, I'll call it, due process steps relative to what was done before. So we start out with the notice of preliminary findings. On complex audits, there's an exit conference process whereby providers can bring up their concerns or contest findings in the preliminary finding notice. And then the final step is the informal reconsideration process. At that time, or following the discussion with the provider in the informal reconsideration meeting, at that time is when the department, in conjunction with HMS, will issue the notice of informal reconsideration findings. And that's what triggers the overpayment obligation, as well as the provider's ability to seek further review by the administrative law judge. Uh, so it it turns things around is how I think of it. There there's a whole bunch of other items in Senate Bill 314 to help, really assuage the provider community's concerns that the department and its vendor were not uh, listening to the providers, but you know, just to make the process more fair. Uh, Also, the volume of claims that are in an audit regulated by the bill. But then the bill also imposes certain obligations to cooperate with the department regarding audits.
Thank you.
Thanks, David. Any other questions? All right. So I'm going to bounce back to Dr. Chapman. He is going to introduce, we have a new board member who's joined us, and his name is Dr. Justin Beverly. And I'm going to leave that to Dr. Chapman.
I just want to thank Dr. Beverly for agreeing to join. And this came about, Dr. Beverly works at Children's Hospital, and he's the medical director of utilization review. And so we've been having some discussions along with some of his colleagues. And the valid point brought up was that when we talk, and certainly some of it's my bias because I took care of mainly adults, we don't necessarily take into consideration the pediatric viewpoint. And so I suggested that we get a pediatric viewpoint on the board. And so, like I say, Dr. Beverly has agreed. He trained down in Georgia, has an engineering background, did a pediatric residency, has worked at Intermountain Health, so he's got a little bit of experience in other systems besides CU, but now is a hospitalist, and like I say, has some varied experience as a medical director, a financial liaison, and now is doing utilization reviews. So lots of good perspectives. So thank you, Dr. Beverly, for agreeing to join us. And I'm just gonna um, go back a little bit. The purpose of these meetings is to get input, get the provider's perspective. So if there's something that you guys want us to cover or something that you say, oh, this is a waste of time, please let us know. We really, the idea of this is to get you involved so we know what your interests are. So again, thanks, Dr. Beverly, for joining us. And if you
Thank
want
you.
to introduce yourself, you're more than welcome to.
Yes, I will. Thank you so much. I do appreciate the introduction, though. Yes, hi, Justin Beverly, friendly neighborhood pediatric hospitalist, and yes, my Georgia drawl, I'm sure, will come out in the meetings. And for the last about 5 years, I've been doing utilization review here at Children's. There really were no physician advisors, and really not a physician led kind of a utilization review program of any consequence before about 5 years ago. And so this is a still growing and developing program, and I just appreciate the opportunity to be a partner. I think the problem I have here at the beginning is that I feel as if I know a small slice of this universe very well, and other people know so many more things than I do. And so I wish that I could bring 5 or 6 people with me to each of these meetings, but alas, we probably wouldn't get anything done if we did that. So, but again, I appreciate the invitation.
And I'm kind of going to put you on the spot. Welcome, Dr. Beverly. In the beginning, when we had the board, I kind of like to humanize everybody. So is there something that you would let us know that's interesting about yourself that you like to do outside of work?
I have nothing interesting outside of work.
No?
I'm in spreadsheets all day, every day. That's all I do is spreadsheets.
You have
And so
no.
basically, AI is going to take over my job very quickly. I got to like do farming, or I got to go back to engineering or something because AI is coming for my job. I'm here to tell you.
Yeah, it sounds like we need to get you a hobby too.
Yeah. No, I have 3 girls, 3 teenage girls, and they keep me busy. And I'd take 30 if my wife would let me. I just love kids, and probably me living my best life is being in charge of an orphanage somewhere. Okay, so uh,
Awesome.
But no, I appreciate the putting me on the spot, but no, I'm quite boring. Don't dig too deep or you'll all fall asleep. I'm a good cure for insomnia with my habit, my hobbies in the background. Okay.
All right, I appreciate your honesty and thank you for answering the question. Okay, so with that being said, like I said, welcome. And I'm going to turn it over to HMS to Matt and Wendy to go over the 5 case scenarios that we have.
Awesome. All right. So all 5 of these, I think, are pretty. They're pretty straightforward. So I'll give you a kind of a brief overview of each one, and then pause obviously between to take any questions that anybody has. This first one is behavioral health fee for service paid at the same on the same date as an encounter claim. So for this one, we're looking for essentially these are exact duplicates, right? It's the same date of service, same member, and same provider, same code paid, except for one of them is paid by one of the regional accountable entities, RAIS, one of the behavioral health organizations, and then the other one is paid fee for service. And so we are qualifying on services that should be provided by the RAIS, and so therefore we're recovering on the duplicate, the fee for service duplicate. And that is essentially the concept here. Again, just basically a exact duplicate, one paid by one entity, the other paid by fee for service. Any questions on that one?
Hey Matt, it's Shara. I do have some questions here because I thought, okay, so obviously Denver Health, we're an FQHC provider, right? So I have some uniqueness that I deal with. You know, I have 8 billion MPIs and I deal with all that kind of stuff. So we're still entitled to one behavioral health, one medical, one dental encounter in the FQ world per patient per day. That's still a rule. So can we kind of understand as a patient, you know, and specialties like I guess I'm trying to understand with the RAIS being behavioral health and then the medical side, how are we looking for things that should have went to the RAI but went to the medical side? Can you kind of further elaborate on that? Maybe because of the FQ thing, it's convoluted in my brain, you know, maybe I'm stuck on that, but I thought there are definitely situations where patients may be entitled to more than one, depending upon the criteria of what they're being seen for, who the specialist is. Are those things being taken into consideration in this review?
Yeah. So at a very basic level, like this is a claim for the same service, the same provider, the same member, and so and then all of the services are behavioral health services that we're looking for. So that overlap of a medical and behavioral health claim should not happen. But then outside of that, like one of them obviously is being billed to the RAI. The other one is still a behavioral health claim, and it is being billed to fee for service.
Gotcha. Okay.
And
I'll be completely transparent. I have not. These just came to us yesterday, and you know, my day job is a little bit busy right now, end of year, and you know, things. I didn't get a chance to read these, so I'm learning as we go. So not sure if in the future maybe we can get these a little bit more in advance. I was going to make that as a request because 2 days is definitely not always going to give me the opportunity. It's variable, depends on what's going on in my day-to-day world. Because you know, day jobs sometimes get a little bit crazy.
No, ideally that's what's supposed to happen, but unfortunately with everything going on and rolling everything out with the pilot, They were just given to me in the
Yeah.
morning. So,
And I
in
figured
the
so.
future, yes.
Just being transparent that I'm the
Oh, I
first one to
appreciate
tell on
it.
myself anytime I didn't read them ahead of time. So, naughty classmate here, I didn't do my homework, but learning as we go. So if I ask any stupid questions or make any stupid comments, I make my apologies in advance because I am not educated yet. I'm learning as we go today. So with the exception of the EFT one, I'm very educated in that one, Megan, because that's what I've been spending a lot of time doing.
I know.
Go ahead, Dr. Braun.
Yeah, I just had a quick question. I just want to clarify something. If you have someone that comes to the emergency room with, let's say, suicidal ideations, and then they evaluate them and say, you know what, this person needs to go to inpatient psych, and then they discharge to inpatient psych. Does the emergency room still get paid any kind of a fee? Would that be considered two different fees on the same day? I'm just
Not
trying
for
to
me.
understand.
Not for me because they just get admitted and go upstairs, I guess. So for
Well,
us,
that's if you have inpatient psych in your building.
yeah. So us,
We don't have that.
okay.
So Stephanie, you can correct me if I'm wrong, but I believe that is one of the exceptions, is if someone is seen in an emergency room or inpatient, that's a different animal. And Stephanie, am I speaking correctly?
Well, actually, that's a question for Matt and Wendy and how that is set up, but I believe you are correct.
Yeah, because I thought this came up when we were talking about it.
Yeah, because I know that a lot of times on those ones, we'll see them in the emergency room, then we put them on a behavioral health hold where they're in kind of a limbo status, not observation, not inpatient, just sort of there, and then waiting for a bed to open up. And sometimes those beds can take days.
And that makes sense. And but this is this concept is identifying something different than
Okay.
that. Like in this one, like the provider is billing the claim to both the Ray and to fee for service. So like whether it's an observation claim or an inpatient claim or an outpatient claim, that single claim is being billed to both entities
Okay.
for that same date of service. So
So if these are going to different entities, it doesn't really flag per se if it was like a transfer in care.
right. So if you
Okay.
had one claim, let's say you had an outpatient claim and then an inpatient claim, and those went to separate entities, that would not flag in this audit because they're not both being billed. Or I'm sorry, one of them is not being billed to both entities. It's two different claims being billed to two different entities. That's okay.
All right. Thank you.
Yep. Anything else on this one?
Mm-mm.
All right, I think we're ready for the next one, Kelly, please.
All right, so this next one is pediatric behavioral therapies disallowed place of service. HCPF policy outlines the appropriate places of service for pediatric behavioral therapies. This concept is identifying claims that are paid for PBT services and have a place of service that is not one of the allowed place of service codes listed within the PBT policy. And if you scroll down just a little bit, there will be a list of this list here is the list of allowed place of service, and so this concept is identifying services that were paid outside of those. The one that's a little bit different is that place of service 03, which is a school setting. That one became allowable May 3rd of 2024. So before that May 3rd, 2024 date, that would be non-allowable. We would be identifying those claims as overpayments. After that May 3rd, 2024 date, those would would no longer be identified as an overpayment. What questions can I answer there?
No questions?
I don't have any.
All right, I think we're ready for the next one. Please, Kelly.
All right, so this one's somewhat similar. So we're looking at pediatric behavioral therapies with an incorrect provider type. So again, HCBUF policy outlines the appropriate provider types for PBT services. And so we are identifying claims that are billed by providers that do not fall into the appropriate provider type or types. So the and this one also has a date where there was a change for provider type 25 up until mid-year of this year. Provider type 25 was allowable. The provider just had to re-enroll as provider type 83. But that changed, I think 7/1 of 25. So as of right now, those would not fall into the audit period. But once they do, we would then be looking to identify any claims billed by that provider type 25. So this one, again, just looking for provider types, unallowable provider types providing these services, and those would be identified as overpayments. Any questions I can answer on that one?
Nope.
Okay, I think we're ready for the next one, Kelly. Please.
All right, we got another pediatric behavioral therapy concept. This one is PBT services without an ordering, referring, or prescribing provider. So HCBUF policy outlines the requirements for PBT services. One of those is that that the service has an order from one of the qualifying provider types, and then there is also policy that says that an ordering, referring, or prescribing provider has to be listed on the claim. And that is also a federal requirement. And so we are identifying claims that were billed and paid that do not have an ordering, referring, or prescribing provider listed on the claim.
And I'm assuming it's okay for people to self-refer if they're one of those categories, right?
So at this, this concept is identifying where there just is there is not an ordering provider on the claim. So it's not that they're reporting that they're the referring provider. These ones have no referring provider.
So let's say, for instance, I have ADHD and I go see a psychiatrist. Do I need a referring physician if I self-referred? Or can he just go ahead and treat me and it would code under his name and this is not applicable? I'm just asking.
So the requirement still stands that the referring or ordering provider has to be on the claim. So
Mhm.
I would say in that scenario, the provider should still be entering something there.
Dr. Braun, I'm going to say from a compliance standpoint, I think there might be some rules against self-referral, but I'm not positive. I'd have to research that for you. There might be limitations, and it might be dependent upon payer.
Okay. I didn't know the answer to that, and that's why I was asking, because I could.
Those are the kind of questions that come to me to research and find out the answer for the organization. So if you are wanting to self-refer, I'd have to do the research for you.
Yeah.
Well, and it's a great question, and I think it's one that we can also take back and if there is something, right, that we need to adjust for this, if there's an adjustment that we need to make for that, we can absolutely do
Yeah.
it. So I appreciate you flagging it.
Yeah, and I know the ability to self-refer is its own little flag because people abuse that too. So I'm just asking the question.
Yeah, no, it's a great
I don't
question.
know, but I think in theory with people with good intentions, it's not a problem. But if you have someone with bad intentions, it can be a big problem.
Yeah, one of the things that gets very sticky is if the physician has a financial interest in the entity that they're referring to, then that becomes for sure a problem.
That's what I was saying.
And it looks like Alex raised his hand. So Alex, take the lead.
Yeah, and I'm not sure if I could provide like a definitive answer, but I could help explain sort of what this program is a bit. So PBT isn't necessarily like a psychiatrist helping somebody with their ADHD. This is more geared around really autism treatment for children ages 0 to 20. And these are predominantly provided by PBT practices that are unrelated to major medical primary care practices or things like that. And so that is why the policy does exist, that someone has to be ordering and substantiating the medical necessity of these services.
Okay.
Do we have any other questions? All right, I think we can go to the next one, Kelly, please.
All right. So this one is NEMT services, non-emergent medical transportation services without a corresponding medical claim. And this is very similar to one that I think we already presented here, which was EMT services without a corresponding medical claim. And maybe we didn't present that one here. Either way, this one is NEMT services without a corresponding medical claim. Essentially, what we're looking for here is a non-emergency medical transportation trip where there is no medical claim or qualifying claim for that particular trip. So one of the in HCPF policy, one of the requirements for the NEMT service is that there is a destination that would be providing a covered service. So what we are doing is looking for those trips where there is no doctor's visit or any other covered qualifying service to necessitate that particular NEMT trip. So we are not including any services that are provided in the home or DME services that are being delivered to the home. obviously those would not count if the member was being taken somewhere by an NEMT provider. And then for this one, obviously, if there are certainly some circumstances that we've kind of talked about where the NEMT provider is not the one who is responsible for the other claim being billed, and so if the NEMT provider is able to provide a trip record that has a that meets all of these all of the criteria here in the policy, then those claims would be overturned, and we would not seek recovery on a legitimate trip to a covered service. Yeah, Dr. Braun.
Hey, Matt, you answered about 90% of my question,
Okay.
but I have one other part though. If a patient asks to be transferred to or taken to his doctor's office and then ends up leaving there before he's seen by his doctor, so no charges are generated, who gets the bill? Does the patient get the bill for the non-emergent transportation? Or does the state just eat it? I don't understand. I mean, that's something I'd really like to know because I could envision this being abused by patients, if targets next to their doctor's office.
And I could say that in terms of this concept, that is a scenario that we would, if the NEMT provider brings the member to a doctor's office and they believe that the member had a visit that day,
right. Yeah, they're doing it in good faith.
Right. We aren't going to, we would overturn that. And if they were to provide that trip record.
So what is the consequence to the patient who does this?
I can't speak to the consequence to the patient.
Because the bad actor needs the consequences.
I agree there, but I don't know that I can't speak to what happens after that. Like we overturned that particular claim,
well, that's fine.
And the provider would not have to reimburse the state for that.
Well, that wouldn't be fair for the provider to pay it. So no, I understand.
Well, and Alex, I don't know if you have anything to weigh in on that too, because this question has probably come up to you a few times.
Yeah, thanks, Stephanie. I was thinking about this. So my team actually oversees the NEMT program at the department. This particular circumstance of if a member was purposefully abusing the coverage to use this as free transportation around town under the guise of being brought to a medical appointment, that would be investigated by the fraud investigators, and charges would happen accordingly like that. There's nothing really that the department has to automatically detect that kind of behavior. Certainly if there's a pattern of this happening, that just becomes more information that's given to the investigative team. But usually the sort of abuse of this we see is from the NEMT provider, because they are the ones actually receiving money to provide the trip. And we can see patterns where, there's actually very interesting data around which providers have the highest percentage of trips to nowhere. But Ashley, do you want to take it from here?
Yeah, I was just gonna to echo that from the fraud, waste, and abuse division's perspective, if there was an indication that a member was acting inappropriately or fraudulently, we have mechanisms to investigate those scenarios, they would move through potentially criminal proceedings, overpayments, etc. I think to echo Alex's point, though, and a lot of the reviews that we have done on the trip log, you're required to have the address to which you dropped that member off at, as well as, I believe, number 6 is the attestation that it was to a medical facility. And what we've seen in claim reviews is that those addresses are not to anything close to a medical facility. It may be to a fast food restaurant or to a grocery store. And that's where I think the discrepancy between whether the provider has done something wrong versus the member can be flushed out a little bit more once they provide us additional information on the claims.
Sounds good. Thank you.
So I have a question on, because I have been doing some research, obviously, on the first pilot of this, and I'm going to be giving more information, feedback later on next week. But what is the reasoning of this one being an automated review versus HMS actually requesting the trip reports and doing an overview ahead of time? Because it seems to me counterintuitive that the provider can send the trip report and dispute this finding versus you guys actually requesting the trips and doing the research and doing the review, like a medical record review, essentially. Because I get the fact that this is a trip to nowhere, but it's not the onus of the ambulance provider to submit that report after the fact. It is of the facility receiving the patient. And so I'm curious to know what the rationalization behind that, what's the data that proves that's the better approach versus the records being received, HMS doing the work instead of the onus being put on the provider or the ambulance company. Because and I'll share this information with HICPUF next week, but will state that my finding is that it's typically something happening on the facility side. And being in the shoes of the ambulance provider and the pilot project, I have a little bit of a different approach to it because, the pilot person being the fact that we own our own ambulance at Denver Health, I have a little bit more ability to see data that a typical ambulance provider isn't going to be able to, because I also have access to DHHA's information. You know what I mean? Like, I have that extra ability, which I think a lot of ambulance companies aren't going to have that same ability to see medical records of a hospital. So, a lot of patients go between Denver Health and then all the other facilities in the area. So I feel like I had a little bit of a leg up on it, where other ambulance companies aren't going to have what I'm able to see. So when I'm going in and looking at a trip report, I can just see what the trip report of my paramedics did, right? I also can see what Denver Health and Hospital did in some cases, not all cases. In those other cases, it's kind of a frustration to me because I can see the trip report, I can see what happened, but I don't know why St. Joe's did what they did. I don't know why Rose did what they did. I don't know. And so to me, I would think that the ability of these audits should be based off of the ambulance and the trip report and what they did, not the fact that Rose didn't do something, Denver Health didn't do something, St. Joe's didn't do something. So that I just kind of like to understand the approach to this as an automated audit versus a review audit, of the actual trip reports and the documentation.
And Shauna, sorry, Dr. Jeff, I just want to make one quick point of clarification. This particular audit is not actually emergency medical transport. It's non-emergency medical transport.
But it would be the same concept. Both of them are automated, right? They're both
yeah.
So I just like to understand in both cases, what's the intent of putting that in an automated sense versus a more in-depth approach of asking the ambulance providers to submit their documentation for review prior to making a determination?
Well, part of the reasoning is it's incredibly time consuming to do that, as you well know. And so it does, in fact, put the onus on the provider to say, if you dispute this, then you can send us your records, right? And we will do a record review. And so this one in particular for non-emergency transportation, we have done, oh gosh, Alex and Ashley, literally thousands of record reviews for NEMT over the last year. And we are we are in a position where it's time to start saying, providers, you have to be responsible for doing this correctly. And so if you can't, we're going to audit you for that. And if you did do it correctly, then you have to show us that you actually did.
Yeah, and I don't know about this particular one. I can tell you on the EMT one, and we'll talk in depth, about what my
Yeah,
findings were.
it's totally different on the EMT
Yeah,
side,
the
and I'm
EMT
really
one, I'm going
interested
to
to
tell
hear.
you,
Yeah,
I'm not in favor of, because I have spent a lot of time doing it, and
Yeah.
it's like, this seems fruitless on my part, because yes, there's going to be some errors, right? Anytime you do an audit, in my opinion, even when I'm auditing internally on my providers and such, I feel like there's always going to be a percentage of errors. If you're not making some kind of error, you're not human, in my opinion, at least a little bit, But overall, I'm like, wow, this seems really like the tables. I see it as a huge provider dissatisfier in the rack world. I know that's what we're trying to kind of get away from. I think the EMT one would be problematic personally, but we can talk in depth next week on some of that stuff. And I'm not from the ambulances outside, Denver Health does a company that does our stuff. So I'm not as in the weeds with that as I am some of the other medical stuff. But I haven't looked at the NEMT stuff. So that could be a whole different ballgame. I was just trying to understand the reasoning, rationalization of automation versus, HMS doing the review up front.
Yeah, no, I totally get that. And I do think there are some differences between the NEMT and the EMT. And I mean, honestly, that's one of the reasons why we're really happy to have you helping us to pilot this and learn from it on the other one. But NEMT in particular is an area where we have been, suffice it to say, up to our eyeballs in doing reviews with providers for, I don't know what, a year and a half, almost 2 years, Alex and Ashley. And so it's time for us to just start saying to these providers, this is what you need to do to prove that you're actually doing what you're supposed to do.
Gotcha. Okay. I was trying to understand that as I was going through the other one. Like, this doesn't make a lot of sense to me, but now that if the NEMT is a different story, that would make more sense. So I did realize they're different, situations. And like I said, I'm not as familiar with ambulance
so like
stuff.
NEMT is, the equivalent of a taxi, right?
Yep.
Or an individual driving their own car and providing services. Yep. So it's a really different
I think of
model.
Like cabulance back in the 20 years ago when
Exactly.
I started at Medicare. That's a term I'm familiar with back in the day. I'm aging myself, but yes. So yes, okay, perfect. That's all I wanted to understand was kind of some of the reasoning behind the thought process.
No, it's a great question.
Yeah, that's really good feedback. And one thing I will say on NEMT as well is that it's these providers. It's a very kind of high volume service, and the automated approach that we're taking allows the provider to only dispute those claims that they think are legitimate. And so then up front, we're not asking them for 10,000 records. We are giving them the list of claims and saying, identify the ones that you want to dispute and provide the records for those claims. And you don't have to provide the record for the ones that you're not disputing.
I want to give you the records though, because that's a different department than me. Just kidding. I mean, don't tell my HIM director that, because she will want to murder me. But oh, just semi kidding. Either way, it's work. But
that makes sense. Yeah.
Any other questions? All right. I think that was the last one, Matt. Am I?
Yeah, I think so.
Okay.
You guys made it pretty easy on me, so thank you.
So just so everybody knows, those documents are going to be uploaded on our website today. And while you guys were all going over that, I did indeed confirm that the November 13th stakeholder was not on the website, but it is now. So the recording and the slide deck is now there for everybody to review under the stakeholder engagement. So to proceed with our agenda, I'm going to give it back to HMS and have Chantel go over the HMS website updates.
Yeah, thank you. So I just wanted to take a few minutes because we are going to be making some changes. We've been working this year to update our HMS Colorado RAC website. We're trying to add additional information, make it easier for providers to navigate to. If we want to send you a link to something directly, we're trying to make it so it's not just a landing page. So we're working on really updating that website to be more user-friendly for providers, have more materials for providers to utilize, and make sure that all of the accessibility requirements are met. So with that being said, one of the things that we are having to do is take our current website and scrub all of the information off of there and just put some real general information out there while we are making updates and changes on there. What we want to include to make sure that, you know, as we start with the audits again, is we want to make sure that we keep the resources out there from the provider portal standpoint. So just wanted to throw it out there because our website is going to look very bare for a little while. I think that our new website should roll out early 2026. But within the next coming weeks, you should see, you know, our website is going to be very bare. It will say, you know, under maintenance, but we will leave those resources out there that are necessary, like I said, such as the HMS provider portal, and then just some additional contact reference information out there. So please don't be alarmed if you see that. I just wanted to make sure that we throw that out there as we are sending letters. We do include our URL on there. And so if you're going to our website, just know that it is under construction. And so we'll have a brand new, beautiful website early 2026 for everybody to use and reference. So that's it, Megan.
Thanks so much, Chantel. And then we will also be mirroring that website. So there's a lot of changes in 2026 with our website as well. And speaking of our website, there's a section on our website that is for comments, suggestions, et cetera, et cetera. And now that hyperlink actually goes directly to my inbox. So, so if anybody has any suggestions, comments, feedback, topics, it's on the first page of our website. It's a hyperlink and it comes directly to me. So if anybody has completed that and you didn't get a response from me, please reach out to me directly, as I've tested it and it's working. And I have a lot of people sending me hate stuff, but I also have the people are utilizing it throughout the department or through the outside agencies through the department to give stuff that's not related to RAC. But it does come to me. So if you've sent something and you don't get a response from Megan Morehauser, then please reach out to me directly. Also with our website, I believe Kelly is going to put out in the chat for everybody that the links to the 2026 stakeholder engagement meetings are up, as well as the 2026, like I said, provider advisory board meetings. And you can just click on that and register for all of them. And then you'll get email reminders as we move forward. So that is all that I have to update everyone with. And like I said, I appreciate everybody working with me. Sorry for Shauna, sorry for the, about 24 hours of reviewing those documents. We're working on that, but with everything going on, it's kind of been tight right now. So with that being said, I'm going to give it over to Stephanie Denning, and she's going to give us a closing. And I hope everybody has a wonderful holiday.
Well, I should first ask if there are any other questions or comments or thoughts from anyone else on the board or other folks that are online here with us today.
Nope. Other than those people need to be nice to Megan.
Yes, we can always promote better online etiquette. Well, I really just wanted to say a big thank you to all of you. I know this has been a long under construction process to get us to where we are today, and we are really truly grateful for each one of you who has chosen to participate in this provider advisory board. And Dr. Beverly, super happy to have you joining the team here. And we hope to add a few additional folks, in the coming year. But it has been so refreshing to have you all engage with us, be part of the process, help us learn as we go, ask the right questions, ask the tough questions, push us a little bit here, push us a little bit there, and be willing to really have that dialogue with us to make this program better. So I really just wanted you all to know how grateful we are for that, for your time. This is a big investment in time. We understand, and we want these meetings to be productive, beneficial to you. So just, kudos to every single one of you for being part of the relaunch of all of this and helping us as we go along. And hope that you all have a great holiday season, a safe holiday season.
Hey,
And
Stephanie, there's one question in the chat that we haven't answered yet.
whoop, let me see where
Yep,
we go here.
I was going to get to that. Someone would like, or Sarah would like us to restate the timelines for automated and complex audits of when they're going to resume.
Oh, sure. So as you probably know by now, our automated audits have started, right? And we've been kind of going through the list of some of the new ones that are going to be coming out. And again, we are very thankful for folks like Shauna who are willing to pilot with us and help us not only really look at the audits themselves, right? But especially right now, how are we doing on the letters that we've completely revised? How are we doing on the many changes in the portal that we've made that we hope are making it easier for you? All of those kinds of things, as we've been rebuilding, a lot of changes, and so it's incredibly helpful for us to have your input on that. So, but our automated audits have started. The complex audits are a little bit more complicated. We will be very slowly launching the complex audits, starting with the DRGs first. And you'll see a few of those come out, we think probably in the next couple of weeks, where a very, very small number of claims for the providers that are on our selection file will be going out. And again, it's really difficult to do a pilot in the same way that we're doing it. For example, Shauna, with your team on the automated side, it's really difficult to do that kind of a pilot with complex audits. So we're starting with very, very small numbers of claims for each provider so that we hopefully will have time to be able to do the same sort of dialogue with you and get feedback from you and help us kind of understand, all right, what's working? Maybe are there things that are not working as well? And we're starting with the DRGs because those are a little easier for us to manage. The place of service audits will probably be launching sometime in the first quarter of 2026. I will tell you the big kind of sticking point right now on the place of service audits. We really, really want to make sure that there is a solid process in place for providers to be able to rebill those claims. And we had just a lot of fits and starts with the rebilling process in the past. And so this is a shameless plug again for guinea pigs, but we may be outreaching a few providers to kind of work with us on some of the new things that we're trying to put in place to make sure that rebilling process works for a place of service. But that's really what we want to make sure that's in place. It's working the way we all expect it to work and want it to work. And then we can really move forward in terms of launching those complex audits. But we want to make sure that that's functional before we start that process, because it's a really important part of the process. So again, if you had a great experience with rebilling before, awesome. I'd love to talk to you. If you had a really bad experience with rebilling before, equally awesome, actually, because we'd really like to learn from you and really like to understand what were some of the issues that you were experiencing so that we can learn from that. So yes, I hope that answers that question. And
There's actually an extension to that, Stephanie. So if the providers aren't in the pilot groups, when can they expect audits?
That's a great question, and I don't have a great answer for you. In part because we're still a little bit in that learning phase, not just with the audits themselves, but like I said, with kind of all of the changes that we've made with letters, with the portal, with, outreach processes, all those kinds of things. So we're trying to do our best to get as much feedback as quickly as we can about the entire process. And we again, we really want to make sure that everything is working the way it's supposed to be working, or the working the way that we expect it to work and that you expect it to work. So, it's just taking us a little bit of time to make sure that we're tweaking the things that we're hearing from different people, putting in place, some additional edits or other kinds of things, updates that we might need to make as we learn from folks. But you'll really start to see things happening early in 2026. So, I would say probably mid to late January is when we're expecting at least to kind of be starting to get into a groove, to kind of be seeing that things are happening the way they need to happen. Everything is working, the process is working through the way it needs to work through. So I would say you're likely to start seeing more activity, more structured and steady activity starting, mid to late January, if that helps.
So Stephanie, did we ever get that letter put together saying that as a result of these audits that we're allowed to rebill at the lower rate without a specific order?
Oh, are
That
you
was that was our sticking point before.
yeah, let's talk about that more. I mean, we don't necessarily have to do it here, but I would
That's
like to
fine.
hear, I would like to come and revisit that because that was part of that issue. Right now, our biggest issue is some on just sort of the technical side of rebilling and being able
Right.
to actually do it in
No, we
in
can
the
do it, just
MMIS
the people
system.
don't want to because of
Yeah.
they want that very specific, you know, policy saying you can do this.
Yep.
Will you do me a huge favor, Dr. Braun, and just shoot me and Megan an email to and maybe include Dr. Jeff too,
And
with the specific language that you were looking at, because that will help us kind of have,
You know what? I have to
revisit
go
that.
back and research it because I remember sending that to you a few months ago.
Well, let us look for it then. Although
I,
Dr. Jeff and I have our challenges with
oh,
Google
I know, and I'm
Mail.
sure you have thousands of email. I mean, if your email box is like mine, finding things from a couple months ago isn't always easy. So,
Well,
but
Google doesn't really like me, so whether it was yesterday or a couple of months ago, it kind of doesn't matter. But let us do some research on it, and then if we need to, we might outreach you for
that
some
would be
follow-up.
fine because
Okay.
what I would do is just reach back out to our contracting people and get the exact language we have. But I know that we put it in all of our commercial stuff and also some of the access, the Arizona State Medicaid. We are
Uh-huh.
do it here too, but
Okay.
we have not done it in Colorado because we don't have that specific word verbiage in our contracts.
Okay. That's super helpful. Thank you for that reminder.
Yeah, no problem.
And I'm going to add on that, Sarah, I'm going to have Kelly send out a link to everyone. It's on our website. If you go to the website and look in the section, where is it? Under communications, at the bottom, it says to receive RAC communications via email, please refer to the Colorado RAC stakeholder contact list request form. And I urge everybody to complete that who wants to be notified via email of the things. We call it an email blast. And it goes into an area where I update the master list. So I urge everybody to utilize that section as well.
Yeah, and Megan, this is where we can put another shameless plug in to folks to please, 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 please remind your teams, update your contact information in the HMS provider portal so that audit information goes to the people that you really need it to go to. So we appreciate that very much.
And I'm going to
Makes a
urge that
huge
the
difference.
HMS portal section is different than the interchange. So
Yes.
you have to update, unfortunately, both of them. So if you could keep the interchange up to date, I say put a reminder on everybody's calendar every year, every 6 months to just go in and verify that the information, because when you did enroll in the provider agreement, you did sign that you would do that for us. So this is the only way that we can keep in communication with you all to get you, the communication as quickly as possible. All right, let's see.
Well, that's it from me. And really, just again, want to thank everyone. Want to wish you a happy holiday season. Look forward to continuing our work together. And as always, contact Megan or I or Dr. Jeff if you have any questions.
Yes, and thanks again, Matt, for presenting today. He's going to be a familiar face for you guys. So I appreciate you doing that for us.
Of course.
And if we don't have anything else, then I'm going to give you guys back time, which is nothing we can ever get back. So I'm going to give that back to you guys. And any questions or anything, just feel free to reach out.
Thank you.
Thank you.
Thanks.
Thanks,
Have a
everybody.
great holiday, guys.
Bye, everyone.